Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast.
Our two sponsors are Integrative Therapeutics, and if you're not aware, Integrative Therapeutics is one of the premier professional brands of supplements available. We use a lot of their products in our office. One of their most exciting products is their specialized form of curcumin called Theracurmin, and now they have an even more specialized, more highly absorbable form called Curaleaf. They have many other products that can be helpful for hormonal balance as well. And now we have our other sponsor for this evening is Dutch Testing, Precision Analytical Labs. And so we have Noah Reed here to tell us a little bit about dried urine testing.
Yeah, thanks for having me. I came down from Oregon, so glad to be here with you today. DUTCH stands for Dried Urine Test for Comprehensive Hormones, so that's what the acronym DUTCH stands for. It's a 4-spot dried urine test, so waking 2 hours later, dinner and bedtime, gives you the average of the sex hormones throughout the day, so it can mirror 24-hour urine, but it's a little bit easier to collect because it's just on a little filter paper that the patient takes at home. Gives you the metabolites, so how the body is detoxing the hormones. You also get adrenal health with that, so you can be able to see the 4 points of the cortisol curve throughout the day. And then the metabolites cortisol, so how much cortisol is being made, how the body is processing it, gives you a little bit of an interesting view there. And then a very small organic acid panel gives you melatonin production through the night and 8-hydroxy-2-deoxyguanosine, or 8-OHCG, which is the oxidative stress marker, all in one easy-to-use test that the patient does at home. We do have doctors on staff, 12 doctors that can walk you through interpretation as well so that you can become the hormone expert for your patient. So that's a little bit about the DUTCH test. If you do have any questions, I'll be here. Love to answer any more questions for you. We do kind of pride ourselves on the 3 things that make us unique. Our comprehensive report that's visually appealing for you to be able to understand your patient's story. The support from our clinical clinicians on staff, and then everything that we do is backed in peer-reviewed journals. So every analyte that we have on our test is actually put in a peer-reviewed journal. Our most recent one that we're proud of is we were published in the journal Menopause, so we were the first functional test to actually be published in the journal Menopause, showing the efficacy of testing and monitoring hormone replacement therapy as a part of your patient experience. So that was a big feather in our cap to be a part of that, and we'd love to talk more about it if you have any questions. So,
Thank you so much, Noah. Our speaker for this evening is Dr. Maggie Ney. She's a licensed naturopathic doctor. Unless you want to introduce yourself.
That's fine. Yeah,
Okay.
I can.
Okay. Yep.
Hi, everybody.
Maggie Ney.
Hi. I'm so excited to be here. I'm really passionate about women's health and perimenopause in particular. I find it a very underserved area in the market. So I love to educate women and practitioners and would love for this to be interactive if you guys have questions. But I'll start a little bit about introducing myself. I'm a naturopathic doctor. I graduated, excuse me, I graduated from Bastyr University in Seattle in 2006. I currently co-direct the Women's Clinic at the Akasha Center for Integrative Medicine, which is like a few blocks away. I recently co-founded Hello Peri, which is an online resource really devoted to educating women about perimenopause. I'm a certified practitioner by the Menopause Society, and again, I just really like to help women thrive through the perimenopausal period with a sense of empowerment. I like to provide the resources, tools, strategies needed to support hormones and for women to truly feel incredible, because I do think this is the time when women can absolutely get after all their dreams, right? This is the week in Chinese medicine, right? The second coming. You can choose your own path, write your own script, but gosh, it helps to feel really good to be able to do that. to do this. Do I need to point this?
Oh. Yeah, I don't think so. You know what? I'll advance your slides for you.
I can do it.
I'll
I
do
got
it.
it.
I'll do it for you.
Thank you.
Okay.
I use so many pronouns, so I do just want to just really quickly say, however you identify with your patients, I do use she, her to identify women, but I know that everyone identifies a little differently, but just for the sake of being clear and not too wordy, as you can know, I chat a lot, so we're going to add everyone is included, however you or your patients identify yourself. Just want to put that out there. All right, we can move on. Okay, so really briefly, let's just review the 4 basic hormonal stages that women go through. So first we have the premenopause time, which is basically from when you get your first period up until when you start perimenopause. Perimenopause is this time when our higher quality eggs start to decline and we begin to experience more fluctuating hormonal levels. So women can have their regular period, but start to have these symptoms, which we'll get into, and you can still get pregnant, but the regular rhythmic flow that women used to experience with the regular upping of the estrogen, the decline of progesterone being produced during the second half of the cycle doesn't happen as predictably. Menopause, technically, is 1 day. It's the 1-year anniversary since your last menstrual period. And then everything after is postmenopause. I prefer to use menopausal years because we get a little hung up on, I'm after menopause, it's done, it's over, I'm through it. But really, once you're in postmenopause, the hormones are low, and you're going to have low hormones till the day you die. So it's not like you're through with it, you're in it, really. Symptoms can absolutely change, though, throughout that time. Okay, so let's talk a little bit about the unique needs of perimenopausal women. So again, this is the period of time leading up to menopause. Hormones can start to fluctuate and symptoms can occur in your 30s. For some, sometimes late 40s. And perimenopause is not always do you guys hear me okay? Yeah, go ahead. Perimenopause is not always a constant symptomatic phase. Symptoms can flare with times of higher stress, and this is a hallmark, is that during this perimenopausal time, hormones become even more sensitive to stressors, right? So if you're, whatever could be situational, lack of sleep, poor diet, if our body's at all under stress, our hormones are more easily affected. Symptoms can last, really on average, between 4 and 10 years. I mean, I just want to just highlight that. If you're feeling like crap, I mean, that's a very long time. And once a woman has gone a full year without a period, they're in menopause. And again, it's the 1-year anniversary without a period, and patients then are postmenopause. And lifestyle changes become more important than ever during this time, right? Sleeping, hydration, nutrition, movement, stress management, quality relationships can dramatically affect how a woman experiences perimenopause, right? I always say to my patients, yeah, in college you could stay up all late, you could drink beer, eat pizza at midnight, wake up and like go to classes and feel like be on your A game, but that just doesn't happen right now. It's not like, I would say again, like you can continue to age with the same level of energy and vitality, even more so than when you were younger, but how we treat our body matters, and it matters more now. Okay, so I didn't really say this, but I am going to focus here mostly on hormone therapy because this is an area that is really not understood. Most practitioners and women don't feel like this is an option during the perimenopausal period, so I like to educate on this. But again, if you have questions about some of the other treatments, please ask me. Okay, so again, we focus on the lifestyle piece. There are vitamins, there's minerals, there's herbs, there's homeopathy. I know you guys are well trained in this area that can be helpful. But a lot of women do need that extra hormone support during this time to really feel their best. And most important, all women need to have a conversation, right? This is what fuels me, is that women are denied the option. Women aren't given the full amount of choices that they can use during this time. So the benefits of HRT really is greater than the risk for most symptomatic women. But currently, I think the most recent numbers is like 4 or 5% of women are on hormone therapy, when really upwards to 80 to 90% would be excellent candidates. Doctors and other healthcare practitioners are not getting good training in their schooling to be able to recognize and how to use hormone therapy safely and comfortably. I talk to a lot of doctor colleagues, they know it's okay, but they don't feel comfortable. Okay, so again, to speak about the unique needs of a perimenopausal woman, I just like everyone just to be aware of, perimenopausal women are usually in the sandwich generation, right? They're at a time in their life where you're experiencing these hormonal fluctuations. Hormonal fluctuations can affect all aspects of our body: mood, brain health, energy, ability to manage stressors. At the same time that our lives are often more demanding and stressful. Many women are at the peak of their career while also taking care of their own children and aging parents. And this is a time for patients really to focus on lifestyle more than ever and prioritize personal health and hormone education so they can really show up as their best version of themselves. And for many women, it's simply a perfect storm that the hormones and life stressors are happening at this exact time that hormones are shifting. So a comprehensive approach to perimenopause, we're looking at, well, we definitely want to get a very good past medical history, a thorough understanding of their current symptoms, family history, lifestyle. So important to know our patients' health goals, because that can help individualize our treatment plan. And focusing on things like nutrition, hydration, movement. And for the perimenopausal women, it's really about getting good cardio, resistance, right? Lifting weights is more important to build that muscle because we lose more bone mineral density as we go through the perimenopause and menopausal journey. So we need to focus on building muscle because what's good for muscle is good for bones. Women need to focus on balance and stretching. For nutrition, I usually say, keeping blood sugar stable, metabolic flexibility, optimizing protein intake. But again, all the other things: morning sunlight, quality relationship, joy, stress management, addressing gut health, supporting detoxification pathways, targeted supplements, and hormone therapy. And if you can include all this in your plan, you're doing comprehensive perimenopausal care. So a few points I want to make that come up to me as a naturopathic doctor. It's like, gosh, I'm a natural, I like to follow naturally things, do things naturally. I want to support the natural process of my body, and I'm supposed to go through menopause. Why don't I just honor that and accept it? It makes sense. But we all need to question what is natural these days. Like, are we supposed to live to 80 and 90? Are we supposed to be, super physical and active mentally and physically? I mean, I know I want to be. I want to be, super active and having fun and hiking up until the day I die. And we're living longer than ever. We used to die just past menopause. And now we're living, up to half of our life after menopause. And to have the expectation that we can do that with the same level of energy and vitality as we did when we were younger is not realistic for most people if they're not using hormones. For some, yes, again, it's individualized, but we just need to be aware of this. And there are risks, I'm not quite done, there are risks to not addressing our patient's health as well. Hot flashes and night sweats aren't just annoying. They're not just something you need to embrace and move through. There are consequences to it. We know that it obviously can disrupt sleep, which can affect every aspect of our life. But there's also more vascular inflammation when women experience hot flashes and night sweats, which does put them at higher risk of heart disease and dementia. Also for women, depression and suicide rates are skyrocketing for midlife women. It is true that suicide rates for midlife women it peaks then. And if a woman is presenting for the first time during this time period with new onset depression or reoccurrence, then it really truly needs to be taken very seriously, and we need to recognize and discuss the hormonal component as well. So what's happening hormonally specifically during perimenopause? So basically our estrogen starts to behave a little bit more erratically. So during the pre-menopause years, our estrogen in the follicular phase basically starts off low and basically steadily increases. It gets to a certain point where it signals to the brain to release luteinizing hormone, which triggers the egg to be released. So we ovulate, there's a little dip in estrogen, and then it boosts back up again, and then it drops. And then during perimenopause, that estrogen just doesn't really have rhyme or reason. I mean, some months it can go regularly just like that, and other months the estrogen is just up and down and up and down and up and down throughout the cycle. And women feel it because our brains like stable hormones. They just do. We do better. That's why women have a little mood issue sometimes around ovulation and obviously during the premenstrual time when we're PMSing. It's because of these drops in hormones that trigger changes in our neurotransmitters that can affect our mood. So again, these estrogen fluctuations can lead to more unpredictable mood changes. 70% of women in perimenopause have mood changes, anxiety, depression, irritability, moodiness, less able to manage day-to-day life, and stressors, feeling less resilient. So the stressors that we used to be able to handle with ease can just feel too much. Estrogen fluctuations can also be a trigger for headaches, more aches and pains, and night sweats and hot flashes. And then as progesterone starts to decline, so often during early perimenopause, it's progesterone, which is the first hormone to drop. That will show up in our clients and our patients as difficulty sleeping, difficulty turning our brains off at night, feeling more anxiety, on edge, and then having shorter cycles. So if you were a 28-day girl, maybe you're more 27, 26, which is why it's really helpful for our patients to track their cycles so we can begin to recognize those subtle shifts. Heavier cycles and more spotting between periods. So these are separating the hormones and getting an idea of what symptoms can be related to what hormones. And because perimenopause can really be a decade, I do think of it as early versus late perimenopause, where the earliest symptoms really are the symptoms of that lower progesterone, which we just spoke about, where periods can start to come a little early. Sometimes you'll have 2 periods in 1 month. You can have heavier periods, clottier, heavier flow, lower libido, ruminating thoughts, anxiety, depression, less resilience, sleep issues. And then the later perimenopause, we're really starting to see women skip their cycles. You just know you're kind of later in the transition. You'll maybe go 3 months, 4 months. And then you'll more likely women will experience those typical symptoms that we think about, hot flashes and night sweats, vaginal dryness. So why, I think this is important just to highlight, why are we not talking about this? Well, first, there's just a lack of training. As I said earlier, there was a recent study that a lot of OBs said that they had maybe an hour of training on how to support menopause, not even perimenopause. So I always tell my patients who come in, they're so upset because they feel so ignored and not heard by their doctor, that their doctors are probably pretty well-intentioned. They're just not educated. There's certainly a lack of research, and there's an underrepresentation of women in medical studies due to historical biases, and also a lot of women have been excluded from studies simply because their hormonal fluctuations are just too hard to control. So let's just not include them at all because men are much more stable. And I think it was only up until, I might be pushing this, it's like the early 90s when women had to be included in studies for medications to be approved. So that's all very recent. What doctor do you see? Seriously, if you're depressed, you're anxious, you're having heart palpitations, you're irritable, you have headaches, I mean, who do you schedule with? There's not really one central hub of a person. So that's why so many people see their therapist, a nutritionist, their primary, a neurologist because they're getting headaches and tingling, a cardiologist because they're getting heart palpitations. And women don't feel heard or answered. And then there's simply a shifting narrative. Our narrative of aging has changed. We are not just going to slow down, right? These 50s, this is the new 20s. Like we're not slowing down. We are active. And our expectations of ourselves are changing. We're not willing to slow down. But there's just no support really in the conventional medical community of how to keep up with that changing narrative. I just think this is really important because there's so many symptoms associated with perimenopause. So the most common one are period changes. It's one thing you can ask from your clients, like have your periods changed? Some people don't know, which is why it's important to track your cycle so you can begin to see mood changes. Over 70% of women experience mood changes during perimenopause. And there was a study that came out a few years ago. They actually studied the term, I don't feel like myself. I mean, how many times have we heard that from our patients and clients? I don't feel like myself. This was actually studied, I think it was published in Menopause. I don't actually know what exactly was published, but they studied that, and over 70% of women said, I don't feel like myself more than 60% of the time over a 12-week period. So it's really common. And then so we have the period changes, the mood changes, and then the menopausal symptoms like hot flashes and night sweats and vaginal dryness. But these other ones are important, and we touched upon them, but less resilient, more irritable, mood swings, heavier menstrual cycle, irregular cycles, tender breasts, headaches, fatigue, brain fog. I know we've heard that, right? Lack of focus, forgetting where you put things, decreased libido, anxiety, weight gain, worsening PMS, hot flashes, dry skin, changes in body odor is one, bloating, insomnia, night sweats, burping, constipation, worsening allergies, ringing in the ears been associated.
I thought weight gain was caused by Ozempic deficiency.
Runny nose, postnasal drip, hair thinning, hair loss, more facial hair, heart palpitations, achy joints, frozen shoulder, right? Things that come up in, you see it more in perimenopausal women. Burning tongue is another one. More frequent vaginal infections like yeast or bacterial vaginosis. Not recovering as well after exercise. Itchy skin, crawling skin sensations, dizziness, and electric shock sensations. I list them out because there's so many. And I always say, like, you need to go get worked up and other things ruled out. But once you do, then you focus on the peri. And so perimenopause is a clinical diagnosis based on symptoms alone and ruling out other causes. It's really important because I see people come in, they say, my doctor took my blood and it's normal, so I'm not in peri. How often have we heard that, right? Our hormones just fluctuate too much throughout the cycle and cycle to cycle to really be, it's just not based on labs. So we can't do a blood test and rule out peri. You can certainly do a blood test, and I think there's a later slide, and it's suggestive of perimenopause, so we'll get into that. But it's really based on how are you feeling, tracking your cycles, recording your symptoms, and then labs to rule out other causes of your patient's symptoms. So the main ones, right, that overlap most of the ones of the symptoms I talked about are your thyroid, anemia, an autoimmune disorder, vitamin D, B12 deficiency. So conventional guidelines, true, say no hormonal labs are needed to diagnose perimenopause. Hormones change throughout the month and throughout the day, and this is all true, and I share that with my patients. But there's really no controversy about testing hormones for fertility, right? Our patients go day 2, day 3 of their cycle, get their FSH tested, maybe get an AMH, get an estradiol, and that speaks to their egg quality, right? If you do fertility, you're familiar with it. If like this 3rd day of your cycle, your FSH is high, that's saying low, poor egg quality. So anyway, you can kind of extrapolate from that maybe you're more in the peri zone. But normal hormones, normal other labs do not exclude perimenopause. They simply provide a little bit more information. Okay, so basically things that are suggestive of perimenopause but not diagnostic. And again, day 2 or 3, if your FSH is above 10, it could be suggestive. Estradiol above 60 with an FSH lower than 10 could be suggestive of perimenopause. And AMH under 1, suggestive of perimenopause. And then as long as you're getting those basic, you might as well get a baseline of your other hormones too. And this is through blood. Okay, I think I said that. So this is important. The definition of menopause is I think, horrific, right? It's based upon if you're getting your period. There are so many women who don't get their period. Either they have an IUD, they had a hysterectomy, they have an ablation. So how do you know if you're in menopause? Well, it really doesn't matter, right? Menopause is just that one day. But what are some suggestives? So an FSH above 35 and an estradiol less than 20 on 2 separate occasions is suggestive of menopause. An AMH less than 0.2 is suggestive of menopause.
The slide before, you said it was FSH above 10, but an estrogen above 60?
Yeah, so basically, it used to be that we just checked FSH.
Okay.
And so if your FSH was a 7, that would be great, you're good, you're not in peri, you should get pregnant, as, from a fertility perspective. But because estradiol, which is released by our ovaries, is the hormone that the brain picks up to say it doesn't need to make FSH. So FSH is the hormone the brain releases to tell the follicles of the ovaries to grow to make estrogen. So during perimenopause, when things are a little erratic, our estrogen can actually be high on the second day of our period when it really should be low. And if it's high, because of just being in perimenopause and lower egg quality, then it can falsely lower that FSH. Does that make sense?
Yeah.
Okay. I mean, this is just comprehensive blood work that I will do if someone's in, who'll see me who's not, I don't feel like myself. So, basics. And then we have the Dutch test, which wanted just to give a shout out to, which again is just another way to assess hormones and how you're metabolizing hormones. So,
Can we see the other? Yeah, we didn't quite get
oh,
that.
sure.
Thank you. Thank you.
Going fast.
So basically, I can talk about this for a second, but CBC, you want to look at, ruling out anemia. Your metabolic panel, that's the basics, your glucose, your electrolytes, your liver and kidney function. Basic lipid panel, maybe you guys know in functional medicine, we're often doing more of the detailed lipoprotein particle size, but just the basic lipid panel. Inflammation with your hsCRP, your sed rate. Homocysteine is, again, a marker for vascular inflammation. I like always to get a fasting insulin for a metabolic health marker. Your hemoglobin A1C, which is that 3-month average of blood sugar. TSH is the overall thyroid health marker, free T4. Sometimes I'll order the antibodies. Sometimes I'll order the reverse T3. Not every single person gets that. Vitamin D, a magnesium, maybe 12, a folate. ANA if you're presenting with more of those joint pains and fatigue even. And then the hormone testing that we've spoken about. I didn't mention this, but progesterone is a hormone that's only produced when we ovulate. So it's always going to be really low that first few days of your cycle. If you get your hormones done day 2, 3, your progesterone's always going to be low. So you only produce progesterone after you ovulate, so just the last 2 weeks of your cycle. So if you want to get an idea of where your progesterone is, you would time your Dutch test, a week before you expect to get your period, or a week after you ovulate. Or you do your blood test, again, a week after you ovulate, or a week before you expect to get your period.
I just wanted to point out, for patients where you're not sure where they're at and their hormones are fluctuating, Dutch offers a cycle mapping, so you can test your hormones every day during the course of a month and kind of see what's going on.
Yeah, so if you're period, you can see some of that more erratic estrogen.
And then
Yeah.
How about if someone is already in their menopause and you want to see how to treat their hormones?
I mean, personally, I go by symptoms. If they're in menopause, they're not bleeding, I go by symptoms, I see how you're feeling, and I might do a blood test to make sure if the number's not too high, or if they're not feeling optimal and their levels are very low, then I'll increase.
for the Dutch panel, do you order that at the beginning of treatment, or is it like throughout treatment?
I think the Dutch panel is amazing. I don't necessarily order on every single person, to be honest. It's not mandatory. I do discuss it with my patients if they're curious to dive a little deeper, or if they're having any of the symptoms that I think I would need further support with looking at the metabolizing hormones. But I would say I like to, when I think if I'm gonna choose a time to do it, after they're on the hormones, because I want to see how they're metabolizing the hormones and make sure they're going down the good pathways. Because you can feel amazing, it's true, and still be maybe pushing it down the 4 pathway, right? 4-hydroxyestrone pathway, where you would want to do some more antioxidant work and try to push more towards the 2 pathways. So if I get them stable on a good dose of hormones, then I really want to dial in on further support of how they're metabolizing, because it's not just about how much hormones you make that control how you feel, but it's also how you metabolize and clear hormones. So let's talk a little bit about hormone therapy, because there's so much confusion. So let's just get really clear on a few things. HRT stands for hormone replacement therapy, and it's an umbrella term. It includes bioidentical hormones and synthetic hormones. And so bioidentical hormones, I think it has been considered now kind of a marketing term. That's what a lot of the conventional doctors will say. It's marketing, and I sort of agree, but it does have a meaning. It means that the hormones have the same molecular structure as our own hormones.
And they don't come from horses.
They don't come from horses, right? Like Premarin. So we're going to talk about that. But I think I need to. No, that's okay. So HRT is the umbrella term. It stands for hormone replacement therapy. Technically, when you're talking about using hormone therapy for perimenopausal women and menopausal women, the correct terminology is MHT, menopause hormone therapy. Hormone therapy is another term that is kind of the correct usage. And the reason usage, because HRT technically is about replacing lost hormones. So if you're 27 and you've gone through early menopause, premature menopause, then you would be on HRT. You would be on a much higher dose of estrogen to replace it. But we're really using low-dose hormone therapy, and it's a technicality like tomatoes, tomatoes, but I want you to be aware of it because it's slowly changing when people are talking about hormone therapy. So HT is used a lot, like hormone therapy, EPT is estrogen, and progestogen. So progestogen is another umbrella term that includes bioidentical progesterone or progestin, so it's an umbrella term. And then BHRT is bioidentical. And then, HT, HRT, MHT are often used interchangeably. So synthetic hormones, they've just been chemically altered. They're not identical to human hormones. So let's just talk about what are some examples of the synthetic hormones. So there's Premarin, which is what Ben was just talking about, conjugated equine estrogen.
How did that come about? Let's give horses hormones to women.
Well, okay, it actually came about because they used to grind up human ovaries to start, and then they would use pregnant women's urine. That was you can't produce so much of it, so then the horses were the next one, so. Oral birth control pills, it has ethinyl estradiol, which is a synthetic estrogen. A marine IUD contains a synthetic progestin, right? It has the levonorgestrel. And this is nitpicky, but it's true. Just because something's synthetic doesn't make it natural, right? Horse urine is still natural. I'm just putting it definitely elicits the ick factor, but as if we're talking about correct terminology, it just means that it's chemically altered. It's not identical to our own hormones. And then bioidentical has the same molecular structure as our own hormones. So bioidentical hormones are plant-derived, so they're made from soy or Mexican wild yams. They're converted into hormones in a laboratory that have the same molecular structure as our own hormones. There is no soy or yam in the final product. But because bioidentical hormones look and behave like our own hormones, they can naturally integrate into our own body's physiology to help restore hormones balance better. And this is important. There are FDA-approved bioidentical options, meaning you can get them at CVS and Rite Aid, bioidentical hormones, or compounded hormones. So let's talk about the FDA-approved bioidentical hormones. This is an area, I'm telling you, people are really confused. They want to talk so much about, I want to go on bioidenticals. I see patients come to see me asking for bioidenticals, and I say, what are you on? I'm on the patch. I'm on the estradiol patch. That is a bioidentical hormone. So again, it's about just clearing up the misinformation, educating our patients, and together coming up with the best choice for them. So FDA approved means the hormones are evaluated for safety and effectiveness. All the FDA approved bioidentical hormones are dispensed with package inserts containing extensive product information with detailed risks, potential side effects. They're commercially available. You can get them at any pharmacy. And so some examples of FDA-approved bioidentical hormones that are available right now are the estradiol patch, the gel, there's a spray, there's a ring, there's an oral tablet, there's vaginal estradiol cream that works locally, not systemically, there's progesterone capsules, and there's DHEA vaginal inserts. So those are all the bioidentical FDA-approved hormones available. So let's talk about the compounding hormones. So the advantages of using compounded, they allow for different routes, dose, formulations. They're just not available through a regular pharmacy. You can allows for products with the fewest ingredients. So commercial products tend to have more inactive ingredients. I will say, vaginal estrogen is so important for women. Like everyone should be on it as they go through menopause because I think 100% of women have some sort of vaginal dryness that can affect the genitourinary syndrome, right? More frequent urination, more prone to UTIs. And I prescribe vaginal estrogen all the time. It's definitely underutilized, but the commercially available one has parabens in it. It just does. And it's one of those things when I talk to people or I'm out in the medical community, it's so underutilized. It's like taking food away from starving children and saying, oh, but it's not organic. It's kind of like that in my mind. So I want it out to everyone. But to savvy functional medicine practitioners, like that's just something to be aware of, that the vaginal estrogen does have parabens. So I will let my patients know. Maybe some of them don't care, that's fine. And some are like, I do everything I can to avoid parabens in my skincare, so can we get this compounded? And then if you have like mast cell sensitivity patients, people are really reactive just to everything, then I go towards the compounding pharmacies. So what are the common compounded hormones? So we're going to talk a little bit more about testosterone, but there is no FDA-approved testosterone hormone for women. So you can get it compounded. Estriol is a weaker form of estrogen. It's great for vaginal dryness, and there's some great studies on it. Sometimes I'll get compounded estrogen and testosterone. We talked about how everyone should be on estrogen cream, but there's a boatload of androgen receptors in the vaginal tissue that respond very well to testosterone. There's bias, which was really popular after the Women's Health Initiative study. If you recall that study that came out in 2002, we can talk more about that if you're curious. And then progesterone capsules, the pharmaceutical ones have peanut oil, so you can get it compounded without peanut oil. You can get a sustained release because it helps with sleep. So, some people like, I've been sleeping better, but gosh, it's not lasting through the night, then I'll think about using the sustained release. So what are the FDA-approved indications for hormone therapy? That means there is no controversy. Like you can just go ahead and do this. You don't need a consent form. You don't have to be worried about anything. If you're struggling with any of these symptoms, these are FDA-approved reasons for using it. If you're having hot flashes and night sweats, low bone density, so if you've been diagnosed with osteopenia, the hormones are FDA-approved for that. Premature hypoestrogenism, that's just if you go through menopause before age 50, everyone should be on hormones. And then genitourinary symptoms, so vaginal dryness, painful sex, urinary frequency, frequent urinary tract infections. These are all the FDA-approved indications. But hold on, we know from a lot of studies that hormone therapy these are studies to support it, can help with your mood, sleep, brain health, joint health, quality of life, and prevention of heart disease. That is well known, and heart disease is the #1 killer in women. So if we're talking about FDA-approved indications, do you know what is most prescribed for hot flashes and night sweats? Do you guys know? SSRIs.
No.
And it's an off-label use of SSRIs is to treat it for hot flashes and night sweats. Depression that comes up during perimenopause. What's the root cause? Probably the hormones, right?
Oh, women are just complaining again.
So during perimenopause, depression, anxiety, more likely to happen. What's most likely prescribed? SSRIs. But the root cause is hormones. But the thought of using hormones to address depression or anxiety during perimenopause is like the craziest, reckless thing because it's an off-label use. We use off-label use of medications all the time.
It's being used for IBS.
Yes.
For sure.
Yes. Crazy. Okay, so these are symptoms where you think, maybe I'll use some estrogen. Hot flashes, night sweats, depression, anxiety, irritability, brain fog, low libido, joint pain. Menstrual migraine, super common. If someone gets a headache right around ovulation, because we said there's that little dip of estrogen, or right before the period on the first few days of your cycle, a little bit of estrogen can just kind of buffer that dip and can make a profound difference for people. Any skin changes, I'm so itchy, burning tongue, ear ringing, or any of the genitourinary syndrome, like any of the vaginal dryness or urinary tract symptoms, you would think estrogen.
Why is it no longer known as atrophic vaginitis?
This is a horrific name.
Oh, okay.
Atrophy. I'm sorry, can we just say men get ED as their rebranding from impotence to ED, right? That was like the most brilliant marketing campaign Like we got the suits, we got ED, right? No longer impotent. Like that sounds horrible. Women go from atrophy, to GSM, basically. It's not quite as great as like impotent to ED, but anyway. So again, these are things we're thinking of using estrogen therapy for. If you have a uterus, you always need to have a progesterone to be with it to protect the uterine lining. Yes?
Was there something that changed last year where insurances can cover like different diagnosis codes for like just primary like hormone deficiency or no?
You mean to cover HRT?
Mm-hmm.
HRT is usually covered by insurance. Like it just depends on your insurance if you use the commercially available ones.
We're a cash pay program, but like for patients that are applying for reimbursement, I was just curious about something that if we gave them like a diagnosis code, could they use that?
For hormone therapy?
Mm-hmm.
To get it through what, like CVS?
Compound. Well, so they pay us a membership fee for it, and we either do pellets, creams, injections, and then all the labs. So it's like all included in the membership, the physician visits and stuff. But I didn't know if there was like a go-to ICD-10 code that you could use for them to submit that for insurance.
I don't know for sure. I think, I don't know actually, to be honest with you. I think, it's a subtle question. I know what you're asking, but I don't know. But you can certainly.
I guess they're billable codes
to get it covered.
Just for like hormone deficiency rather than like those.
I mean, there are for office visits, but as far as medications, I've never had like a prior authorization for hormone therapy. It's just covered.
Okay.
Yeah.
So, but it's okay.
Not through compounding, but through.
Yeah.
Okay. So progesterone, we know that the function, it helps prepare the uterus to accept an embryo. It protects the uterine lining from just unopposed estrogen, which can increase risk of getting dysplasia and endometrial cancer. Progesterone is anti-inflammatory, it's immunomodulatory, it inhibits uterine contractions, it has a calming effect in the mind. If you take it orally, it's converted into the liver into allopregnanolone, which binds to the GABA receptor, so it does have that calming effect. And it does slow the gut, it can help with sleep, causes of low levels, perimenopause and menopause. And then the symptoms, we said it a little earlier, but really when you're thinking perimenopause, you're thinking your periods are coming a little closer together, multiple in a month, heavier cycles, spotting, insomnia, and anxiety.
Do you ever just use progesterone for when you don't want to take estrogen?
Yes, I do. There are actually studies that say higher amounts of progesterone can help with hot flashes and night sweats, like upwards of 300 milligrams. But sure, definitely for like the anxiety and the sleep, progesterone is great. And sometimes I'll use progesterone and testosterone and not the estrogen. But let's talk about testosterone. Testosterone is the most abundant hormone in women, and we have more testosterone than estrogen. Plays a key role in muscle mass, bone health, confidence, and burning fat. It keeps our metabolism strong, our libido high. It does start to decline in our 30s, and 50% of women's testosterone levels have been lost by menopause. So some symptoms of having lower testosterone: low libido, lower confidence, difficulty with orgasms, fatigue, less muscle mass, and difficulty building muscle. So testosterone therapy. So it's not FDA approved for women, which is crazy, but it's just not. Even though there is supporting evidence, we do need more research, but there's supporting evidence for sexual desire, mood, confidence, energy, vitality, muscle health. Possible adverse effects with testosterone is if it's too much for your patient's body, you can have some acne, hair thinning, increased body hair, anger, irritability. But it is endorsed by a number of organizations to treat women who experience, and if this is the clinical diagnosis, is hypoactive sexual desire disorder in postmenopausal women, which is basically low libido that bothers you. All right, so if you have low libido, but it's not really bothering you, and it's not bothering your relationship, that doesn't, you get the definition because it has to be upsetting to you.
Let me just ask, progesterone is available as a supplement. What do you think about women who use something like that?
Yeah, it's available as a cream, topical.
Yeah.
I think if you're using it during perimenopause, that's fine to see if it helps you, but I would not use cream to protect the uterine lining if you're postmenopausal on estrogen. So DHEA, it's also a hormone. It's a bioidentical hormone, DHEA. It's produced by the adrenal glands. It starts to decline in our 30s. It decreases by an average of 60% by the time of menopause. And DHEA is a precursor hormone. Our body turns it into testosterone and estrogen. Our vaginal and vulva tissues are loaded with estrogen and testosterone receptors. So giving DHEA vaginally can be really effective because then intracellularly it's converted into testosterone and estrogen. And again, there is one FDA approved, it's called Intrarosa DHEA that you can get through the pharmacy, but again, you can get it compounded as a DHEA. You can even take DHEA capsule at low dose and insert it vaginally.
Do you like that Beswelling cube?
I learned that from you. So I don't have much clinical experience, but it sounds good. Yeah.
What do you define as low dose?
Like
to be
for-
inserted vaginally?
Okay, so the studies say 6.5 milligrams, so that's like the commercially available one. So you either get it compounded, you can't find 6.5 milligrams, but you can do 5 milligrams. I'm sure you just have to see
Use the
that.
capsule, like the gel capsule, you just
A
insert.
little gel capsule. I don't. It's as long as it
Swallowing
dissolves.
it.
Yeah, instead of swallowing it, you can do it vaginally. You just have to make sure it dissolves. So I would think a capsule may be better than a gel, but I could be wrong. Just as long as it stays in you and doesn't fall out. So yeah, there's not a tremendous amount of studies, but there are some, and it's safe to try. It is. I usually test women, and if they're lower than 100, then I'll start them on like 5 or 10 milligrams just to see if they get a little better. And I have seen it increase testosterone levels in the blood. Okay. So bioidentical, I mean, I've said some of this, but here are the treatment options for estrogen that are bioidentical. You can get the patches, estradiol gels, there's estradiol tablets, there's a vaginal cream, a vaginal tablet, there's rings, and then you can get a compounded estradiol cream. And then we talked about estriol, which has in the past been paired with estradiol in a form of bias. I really don't do that much anymore. That really came out when we were scared of estrogen. We were scared of estrogen after the Women's Health Initiative. So we came out with this bias because you can have estrogen and estriol has a little estrogen effect. So you can maybe reduce the estradiol and have more estriol, but the estriol doesn't have the studies to support the heart health and the bone health. So I just don't think it's needed. Our liver converts estradiol to estriol, so if you're doing the estradiol, which has the potent effect, and give liver support, then your body's turning it into estriol. And then again, for progesterone options, the commercially available is oral micronized progesterone, also known as Prometrium. Again, you can get it compounded without the peanut oil, sustained release, and then there's Crinone gel, which is an FDA-approved bioidentical progesterone gel that is used for fertility and has been looked at a little bit for uterine protection too. Like I said, when you're menopausal and not bleeding anymore and you're on estrogen, you have to be on progesterone. Most women love their progesterone. It's like helps them sleep, it's calming, they feel like a warm, cozy blanket's covering them. Some women feel nothing, they just have to be on it for uterine protection. And a small percentage of women do not like progesterone. It makes them depressed, weepy, bloated. It's a small percent, but it's always good to educate our patients on that. And if that's the case, then I say put it internally. You can take your progesterone, just do it vaginally. The other options are like the Mirena IUD, can be used if you can't take it. And then there's other hormone options as well. So it's always there's always options, right? There's always options. Okay, so
By the way, do you cycle the progesterone or you give it every day?
I give women the choice. I do educate. There's really no studies that say cycling is better or safer. I know intuitively that maybe for some people this feels right to take progesterone to match your cycle, so I fully support that. But some women love their progesterone so much, why would I deny it for them the first 2 weeks, right? If it really helps with sleep and mood and anxiety. So I educate people. Like I teach them. Progesterone is produced during the second half of the cycle, so if you wanted to mimic the cycle, which some people really that feels right to them, I get it, then I'll support them with that.
How about menopausal women?
I don't routinely do it, but I give women the choice. Same thing. I do give women the choice. I don't say you have to do it one way or one way is better. I know people feel strongly about that, but I see people love their progesterone, so I don't want to be like, you can't take it. it's better. I don't feel like there's enough research to support that it is better. In fact, most studies are done, well, there's been some cyclical studies, but it's really just what the patient wants. I educate. I do. So for testosterone, if you wanted to use an FDA-approved form of testosterone, then you would prescribe a man's testosterone that is FDA-approved. They come in like 50 milligram tubes, and you would make that tube or packet last 10 days. It's 1/10 the dose. That comes to about a pea-size amount, or you can put it in a 5 cc syringe and use half a cc a day. I don't usually do that, to be honest with you. I have done it once for someone who really wanted it. So I usually get it compounded for women. And so the average dose for menopausal women is 5 milligrams of testosterone, but I'll usually start at 1 and work up to see how people feel. So these are all your options. If you're getting in the weeds of prescribing or helping women through this, it is important to know all the different options, because I've had patients who can't tolerate bioidentical progesterone. They just feel awful and they need it, and they can't do it vaginally. And I will then look at some of the combination patches, which is a bioidentical estradiol with progestin. So I'll try that, or if I do a tablet. There's just options for people. You just need to, there's pros and cons. And if anyone has any specific questions about the pros and cons of any of these options, I'm happy to go through them. But it's just being familiar, and I don't think we should label things as good and bad. It's just the pros and cons and what's right for people.
But from a functional medicine perspective, which one would you prefer the most of the synthetic progestins?
Oh, okay. So from a functional medicine perspective, I think the IUD is great. The levonorgestrel IUDs, localized progestin therapy is wonderful. That's what I would say. And then you can be on any dose of estrogen, and you're getting the uterine protection. That's what I would say. So we can move on. I'm looking at time. So we can talk about this if you guys are curious about how did we end up to a place when there used to be 80% of women were on hormones, and then it dropped to 2%. Now it's currently at 4, less than 10%. And it's the Women's Health Initiative. So this was the biggest study that was done to look at hormone replacement therapy, because prior to this study, which started in the late 1990s, most women were put on hormones because they saw that during perimenopause and menopause, women just felt so good, and women seemed to be living longer, and it seemed they had all these assumptions from observational studies. Women lived longer, had less heart disease, they were doing great. So they're like, all right, well, can we endorse this as preventative medicine? Can we just say all women should go on hormones? That's a lofty statement. So they put up this study, the Women's Health Initiative, mainly to see not if hormones help with hot flashes or night sweats, but to see do women live longer, and is heart disease prevented? So this was the first, double-blind, randomized controlled study that looked at 2 different groups. It had women with a uterus and women without a uterus. So women with a uterus, right, we said you need to take that progestogen to protect the uterine lining. So they used Prempro, which was Premarin, that's the estrogen from the horse urine, and Provera, which was a synthetic progestin, which I'll talk about it a little later, but it's not the best, it's the worst progestin, to be honest. It's not metabolically friendly, it's not breast friendly, but hey, they were doing, I always give people the benefit of the doubt, maybe to a fault, but they were doing the best they can with the knowledge they had at the time. And then women without a uterus just were put on Premarin. And then each one of those groups had a placebo. Well, in 2002, I'm was everyone here alive then? No, I think so, okay. 2002, it was huge. The study was stopped short because of, the daytime television was interrupted. The NIH president came out and said, we're stopping this study short. Women on hormone therapy need to get off of it. There's an increased risk of breast cancer, heart disease, and stroke. People were so scared. This is how everyone learned about it. No one looked at the study. There was no doctor looked at the study. Patients heard it at the same time. Healthcare practitioners heard it, and it caused such a media frenzy. Every newspaper, every news outlet. This was all over the world, everywhere. And this was, I would say, well, many other people say it. In fact, I'm blanking out his name, but I'll come up with it later. The greatest tragedy to women's health was this, because it got women who were doing very well off their hormones. And like I said, before anyone could really look at the data, and we'll talk about some of the flaws, people that were excellent candidates were taken off their hormones. Women that were 37 who went through premature menopause were taken off their hormones. It was very sad. So I'm just gonna say what we found, and this is with the Prem-Pro group. The women who just took estrogen actually did very well, but this is the Prem-Pro group. So this is where all the fear that came out was based on these numbers. So there were 47 additional cases of gallstones and gallbladder disease. And I put in parentheses the reason why we saw that, and that was because of the oral estrogen that was used. There were 9 additional diagnoses of breast cancer at year 5. I'm gonna just reiterate this, because that's what everyone is so scared of, is the breast cancer piece. This was what was found just in the Prem-Pro group. In the women who took Premarin alone, so just the estrogen, there was 18% less risk of breast cancer. So there was a decrease, a clinically significant decreased risk of breast cancer in the woman who took estrogen alone, yet we are so scared of estrogen. So it was, if you look at it like this, it was the progestin, the Provera part, that may have been the trigger for the breast cancer. But anyway, not to say that those 9 additional diagnoses aren't significant, they are, but the way the media came out made it seem like every woman had breast cancer, like you were putting yourself at such huge risk. And again, it's diagnoses. The women who were diagnosed had better prognoses. They did not die more. No one died more. They just had these incidents, I should say. There were 8 additional cases of pulmonary embolism. That's because of the oral estrogen that was used. There was 8 additional strokes. That again has to do with oral estrogen and the timing. That's another important piece. 7 additional heart attacks. That was due to timing. 6 fewer cases of colorectal cancer, 5 fewer hip fractures, and 0 additional deaths. Okay, so let's just break down what was the problems with the study. Well, the age and health of the women studied, so 70% of the women were over 60. Well, that's not when we usually start women on hormone therapy past 60. We usually start when women are having symptoms, 40s, early 50s. The average age was 63. 10% of the women were between the ages of 50 and 55. We know now, through all the retrospective analysis, that timing matters when you start hormone therapy. Only oral estrogen was used. We know that oral estrogen is more inflammatory, so there's higher risk of clots, strokes, and gallstones. And then the type of progestin used. So only Provera was used, which is a synthetic progesterone. It's not metabolically or breast friendly. Women who took Premarin alone had 18% less breast cancer incidence. So that's like the breakdown.
Would this mean that risks are higher for women that are over 60 that are on hormones?
Not if you start within that first 10 years. So if you start within the first 10 years of menopause, you get all the benefits and you can continue taking it to the day you die and you don't increase your risk. There's a slight increase if you start hormone therapy past that 10-year mark. So you can still start hormone therapy, but the conversation's a little different.
Are you aware of this new study that came out in the Menopause Journal? Women over the age of 65 taking hormones, women who were taking estrogen, lower risk of not only breast cancer, but other forms of cancer, lower risk of heart disease, lower risk of all-cause mortality.
Would you say anyone who's had a hysterectomy should be on just estrogen? Like, is there a reason why someone would not want to be on just estrogen if they had a hysterectomy?
Yes. If you have a history of like endometriosis, progesterone is really and if you have endo, it's really not just a hormone thing or a uterus thing. It's really systemic. There's more inflammation. There's immune modulatory issues. So I would like to give progesterone for that. Anyone who has insomnia, anxiety, they would benefit from that. Even if they don't have a uterus. I don't necessarily put everyone without a uterus on progesterone. But it's like, why don't they have a uterus? And then looking at that as a complete picture, because if it's like very estrogen driven and like I said, like endo, progesterone can be really helpful. So basically, HRT is safe and effective for the vast majority of symptomatic women when starting within the first 10 years of menopause. I've given it to people past that 10-year mark. It's just a different conversation. All the benefits of heart disease prevention is a little different. The study came out in 2002, and then there was all these retrospective post hoc analysis done that did not make the news, right? There was nothing written up about this really important finding. In 2007, it was declared that if you started within the first 10 years of menopause, women live longer, decreased mortality, so less likely to die from all causes. There was improvement in hot flashes and night sweats, reduced incidence of osteoporosis, reduction in diabetes. In 2013, there was another post hoc analysis, 30% reduction in mortality. Women who started HRT in their 60s, no effect with regards to heart disease and mortality, but women who started HRT in their 70s, there was a little slight increased risk of heart disease. And then in 2017, there was a follow-up post hoc analysis. There was reduction in heart disease, decreased mortality, decreased osteoporosis, and reduction in diabetes.
Wait, they were following through on the same people?
They were looking at the same people and they were looking at the data. The results came out in 2002. They just said it as it applied to everyone. Now they're like, let's take a look at this study. Who are these people that had higher risks of strokes? Well, oh my gosh, they were all 72. Wow, in fact, no one in the 50-year range had a stroke. So that's what they were doing. They were reanalyzing the data through a different lens.
Also, too, it could be other factors as they've aged.
Totally.
You know, if they're not overall healthy.
Right.
You know.
Yeah, I mean, a big argument is also that women who are on hormones get their mammograms more often too, so you're more likely to diagnose a breast cancer as well.
Anytime you're in a better mood, you just do things better.
You do things better,
You
absolutely.
remember stuff.
Yes, you remember to schedule those appointments. So timing hypothesis. So when you start HRT within the first 10 years of menopause, the benefits outweigh the risks. We already went through all the benefits. But when it comes to heart disease and dementia, it's timing that matters. So again, why are we afraid of HRT? When you start, hormones matter, the form of hormones matter. So again, oral, more likely to get a clot, the stroke, the gallbladder issue. And really it's come down to, this is the current reasoning, the current argument. It's timing, the timing hypothesis. Estrogen gives the greatest benefit, the most cardiac and cognitive benefits when given early in the menopause transition. And the healthy cell bias hypothesis, estrogen offers the most cognitive and cardiac benefits when the cells are healthy to start, not when disease has already set in.
I have a question between the pill versus the patch. Is it true that you get more protection when you take the pill for the heart and the osteoporosis compared to the patch?
Not with osteoporosis, and then when it comes to pill, there's like a little bit more of a reduction, I think, in LDL, but when it comes to heart disease, same outcome.
Same outcome.
This is just a little bit of a summary. Ideally, if you can start hormones within the first 10 years of menopause, but the sooner the better. I mean, why wait till you're like 8 years post, unless someone's come to you. But like most of the time, these symptoms start early and just straight. It's the best for the vasculature. If you have a uterus, you have to be on progesterone, and consider transdermal estradiol first if tolerated because it's less inflammatory, less risk of clots, and she may be on it for the rest of her life. A lot of people are like, I like oral, I want to just take a capsule. And honestly, if they were on it for 5 years, 10 years, I mean, most people are fine. Less risk of a clot than if you take birth control pills. It's less of a risk. But because women, and now ACOG, Menopause Society, say that you can be on hormones to the day you die, and we know clot risk already increases as you get older, why not just start transdermally if you're open to it?
How about pellets?
Let me finish and then I'll talk about pellets. But I just want to say here, this is true. There's no family history that's a contraindication to starting hormones. So someone could be like, I can't be on hormones because Aunt Sally, Grandma Sue, and my cousin Beatrice had breast cancer. That's not true.
Yeah, I had a handful of patients who had breast cancer, and as soon as I mentioned hormones, all my credibility is gone, right? Because their MD has terrified them. In fact, they're on some kind of estrogen suppression,
Tamoxifen.
but they won't talk, they won't even
That's a little different. I was talking about family history, like mom, but personal history, that's where things are shifting though. It's true because, so often now breast cancer is caught so early, you get it younger, and it is considered a contraindication. I'm telling you what the date, like non-controversial, this is just the facts now, there's no family history, but breast cancer is still traditionally like a contraindication, but, so much is caught early. And what? So women are getting breast cancer and cured, let's say in their 50s, and then dying from heart disease earlier. Having painful sex, they can't urinate, they seriously depressed. So again, and I come back to, it's shared decision making, it's informed consent, it's patients, if you give them the right information in a safe place, can make the best decision for themselves. So things that it would be helpful, if you have a family history of heart disease, diabetes, osteoporosis, colon cancer, we know hormone therapy helps to reduce that. Family history of Alzheimer's. So there's been a study that if you have the ApoE gene allele, starting estrogen early in the menopause transition seems to be neuroprotective. But yes, we need more. There wasn't a lot of research there. Who should not go? This is like, we could talk about the nuances, but this is just the facts. Personal history of a lung clot or pulmonary embolism. A personal history of an unprovoked blood clot. So unprovoked meaning you're watching TV and out of nowhere you get a clot. Whereas provoked, like you had surgery or you're in a car accident, that's provoked. If you're homozygous for factor V latent, if you have a personal history of a heart attack, stroke, or of a stent in place, obviously if you're pregnant, if you have any unexplained vaginal bleeding or untreated endometrial hyperplasia, if you're actively undergoing chemo, if you have active breast cancer, and then that's where I said the prior history of breast cancer, it is a contraindication, but the conversation is changing.
Is that lung clot due to oral estrogens? I mean, is that where that comes from, or?
It comes from, that you already have, you have to figure out why you had that in the first place, but yes, if you have had a history of a clot, then hormone therapy is usually contraindicated. If it was unprovoked, meaning, right, like the clot that travels from the leg, what caused that to happen in the first place. Okay, I think this is the final slide. It's the most important one, and I've said it a few times. The patient and healthcare practitioner, they're a team. And patients really should be the CEO of their own health. Not everything is black and white, especially when it comes to perimenopause and menopause care. There's nuances. And risk and benefits of hormone therapy need to be weighed against quality of life. All of this needs to be discussed openly with the patient to make them feel supported and heard. Is that it? Is that the last slide?
Oh.
Is there anything else? And that's it. So I can take questions I can ask. So this is where you can find me. You asked about, I'll just answer your pellets one. So
They're popular nowadays.
they're very popular. I don't recommend them. We have a new practitioner in my office who does do them. I just presented with her, kind of like comparing, contrasting. But honestly, it's important that patients know there's safe options. Like there's FDA approved, insurance covered options. They need to know all their options. A lot of times women choose a pellet because they didn't get any answers from their healthcare practitioner, and they're searching, and someone mentioned pellets, so they have it. It tends to give like more super physiological doses. There's benefits to it. I know women feel amazing on them, many do. I haven't found that I'm lacking anything in my toolkit with therapies that I talked to you about.
Are they bioidentical?
They're bioidentical.
Okay.
Yeah.
So they could be HABA-free, like there's no.
Yes, and the downside, they're no creams. You don't have to worry about transferring a cream to someone else. If you're working with a very skilled practitioner, side effects are very little. But I've seen in my practice women who have super physiologically high doses of testosterone. I've seen voice changes, clitoral enlargement that are permanent, and I've seen people feel horrible, and I can't do anything to help them because it stays in you. You support them, you can help with liver detoxification, you can do all those things. But I don't like a therapy I cannot take back if someone's having a side effect.
And they just have to.
They have to
wait
ride it out.
like so it clears the body.
Why do that? I mean, so there's arguments. I have like I said, my new doctor in our office is doing them. Why? I don't know. I have safe, effective, insurance covered options. My patients feel amazing. Like I don't need to go there, personally.
Yeah, I think that's one of the complaints about pellets. You get them in, it's too high a dosage. You have to wait for them, rather than using other forms that you can slowly titrate up the dosage to get the desired effect.
Two questions, I'm sorry, so there are standard doses you can't.
For pellets, I mean, you have like one pellet has a certain milligram a dose, and you can, and so hopefully you start at the lowest dose and you can titrate up, basically, yeah.
So there is that option. It's
Yeah,
like
you can have a low dose, you can have a high dose, but even a low dose can be high.
Or
But
if you start with a low dose, now you're gonna wait 90 days to increase the dosage.
Versus like creams, you have a little more flexibility in the dosing, because you can,
Totally, I just like to have my patients have a little bit more control,
Ooh,
a lot more control. Oh wait, you had a question, yes.
How often do you do mammograms on your patients that are on hormones?
I mean, generally once a year, 1 to 2, every 1 to 2 years. And I like the Sonacini too, that's out of network, but it's a really detailed breast ultrasound, basically. It's a nice thing to pair with the mammos. Yes?
Are there like nutrient depletions to consider with hormone replacement, or like lifestyle? How do you support your patients going through with lifestyle nutrition, basically?
Yeah, I mean, that's a huge part. And sometimes it can help just to get their hormones down so that they're feeling better and more motivated. But I mean, I do individualize it, but the overall thing is like real whole foods first. Get rid of the ultra processed foods, and then you can more tweak it. So I do work on upping protein, upping fiber, metabolic flexibility, meaning if someone should be able to fast a little bit, and not feel dizzy and lightheaded. Then when you incorporate the higher protein, the less processed carbs, you can do that better, more easily switch from burning fat for fuel to burning sugar for fuel. So metabolic flexibility, blood sugar stability, and increasing protein are the 3 pillars to supporting women during this time.
Okay. There's not the same oral contraceptives we see like B vitamin depletion.
Oh no,
things
there
like
is not that same.
Oh,
yeah.
that's great. Okay.
Are you using DIM therapeutically ever a certain?
I like to test with Dutch test to see. Sometimes I'll go off by symptoms that they're having a lot of breast tenderness and clots, but the tests don't guess. Like not everyone benefits from DIM because it does lower serum estradiol levels. So, but if I see someone who is not pushing down the 2 pathway for phase 1 liver detoxification, and they're heavily in the 16 or 4, I like to give DIM.
2 questions. One, my daughter, she did that.
Implant?
Yes, for only like 3 months. I think she got actually like 5 years.
Oh.
And it's not gone away. Have you seen that a lot?
I haven't seen that a lot. I just don't have a lot of patients that have been on that. So, but I would say really just to support gut health and liver detoxification would be huge.
And then the other thing is, what do you think of HGH?
I know people really love it. I just haven't gone there. I don't feel too comfortable with all the safety data. I always say I like to learn about it. I'd love to get more studies. My patients feel so good. I don't feel like I'm missing. That doesn't appeal to me to add in my toolkit right now, because my patients are just doing so great with everything else, and there is some concern with using it. And I am a little bit more conservative than maybe some other functional medicine doctors. But the principles of functional medicine, like addressing root cause of gut health, liver, correcting deficiencies, I'm so passionate about that. But then I am also a research junkie, and I do need to see some safety data before doing some of these other therapies to feel comfortable doing it.
What is your therapeutic dose to start for estradiol and progesterone?
It depends who I'm treating, but if it's peri, early peri, the depression, the irritability, they're still getting their period, I do tend to start at the lowest dose. So generally, if you're doing a patch, it's the 0.025 milligram patch. If you're doing a cream or a gel, it's the 0.25. So I start low with the early peri, and then menopausal or late peri, I do typically start at 0.375, sometimes 0.05.
And then for the progesterone?
100 milligrams, but I'll go up to 300 sometimes.
When you go up, can you go down afterwards?
Yeah.
There's no.
Yeah, go by how you feel. Yeah.
Well,
So you give menopausal women a higher dose
Typically, yes,
of estradiol?
I do.
What is the conversation you have with your like mid-60 patients that come in wanting to start HRT? You said the conversation was a little bit different.
Conversation's different with regards to benefits and risks. You're not going to get this, doesn't seem to get the same cardiac benefits or cognitive benefits. Your risk of getting a clot is higher in the first 6 months, not forever. Really, it's that first 6 months where because like the vasculature or blood vessels do better when they haven't taken a break from seeing estrogen. So if there's any like plaque that's developed, estrogen, which is normally anti-inflammatory, can be a little bit more pro-inflammatory when given, after that 10-year mark. The risk isn't huge. It's just you're gonna have heart disease, the prevention of heart disease, the number one killer of women, I cannot say if you're in their 60s.
Probably no studies on this, but like aesthetics wise, like we have so many female patients that want to like improve obviously their skin, their elasticity, like does that improve? Is that
Yes.
a reason that like a 65-year-old woman would want to go on it versus?
Yeah, better to start younger before all the sagging and I mean, there's such a dramatic drop in collagen and elastin as we go through perimenopause and menopause. So, yes, hormones are great for the skin, and even topical estrogen. If you use what we use for your vaginal area, just a little bit under your eye, that's been great. There are some of those like telemed companies that are now giving estriol face cream. Compounding pharmacies are making estriol face cream. But anyway, that wasn't really your question. But yes, even just hormone therapy is good for your skin. Again, not FDA approved, but we can something that it does help.
And Dr. Del Revsing now is giving women in their 60s and 70s, or his protocol for patients with dementia or Alzheimer's.
Replacing that. What about for the osteoporosis?
Hormones.
Estrogen and progesterone.
For osteoporosis, would you have to have testosterone to see a significant benefit with reversing osteoporosis?
Oh, estradiol is only with not osteoporosis actually. To be honest, it's osteopenia. Like it's not. Once you have osteoporosis, maybe estrogen's helpful, but it's most helpful if you can catch it before osteoporosis is when you're in osteopenia.
What about testosterone? Like if you have testosterone?
There's been no studies, but we know it's good for muscle, and what's good for muscle is good for bone. So, yes, we need that. But it is good for musculoskeletal for sure. Testosterone.
I just like most women take estrogen, progesterone, but like testosterone, like kind of left out to dry or like just left off.
It's horrible. We forget about testosterone. It's so important.
You would recommend all of them.
I mean, I'm never like black and white like that. But yes, testosterone would be a nice thing to add to support bone health if you're like osteopenic. But I always, with testosterone, it is a controlled substance, so you do need to do a lab test. Unlike estrogen or progesterone, where you can really go by symptoms, if you're going to prescribe testosterone, you need a blood test. You need to check again 6 months after, and then every 6 months thereafter. You can't prescribe it if your numbers are already high. That's not right.
How do you do your testing? So you start up, let's say, with lab, and then do you do the Dutch test every 6 months to see where they're at?
I mean, I don't. I think it's a personal preference. I really meet the patient where they're at and what they want. I don't know, my patients, some of them are very data driven and want lots of testing done. I go by how they feel. I go make sure their numbers are safe. Maybe a Dutch test at one point. I mean, some people say every year, just to make sure they're metabolizing everything well. But I don't do a lot of recurrent testing if they're feeling good.
And when they're on progesterone and estrogen, they shouldn't be bleeding at all.
No.
So if they're spotting, then if their progesterone is probably not.
So if you start hormone therapy and you haven't bled, if you're kind of anything can happen when you're still peri, right? So let's say you're postmenopausal, you start on hormone therapy. The first 6 months you can bleed. It's not a red flag. We've always been taught postmenopausal bleeding, a huge red flag. You can bleed within the first 6 months. You don't have to get nervous or anything like that. But that can just happen. But after that, you would want to work it up. And in which case, yes, sometimes lowering the estrogen or increasing the progesterone would help with that.
Would you comment on testing, topical hormones, testosterone, salivary testing?
Yeah, I mean, listen, you could talk to a number of different doctors and get a different response. I don't do a lot of saliva. I mean, I just don't. That's not what I do. But doctors do it and love it independent. You kind of do what you're used to doing. I don't do the saliva. I tend to use mostly blood. I get the pros and cons of all of it. I like the Dutch test to add in to see how people are metabolizing, and I go by how people feel. I haven't found that I needed to do like a saliva test to tweak a dose or this or that. I haven't had that issue. I hear my patient, I listen to their symptoms, I look at all their other markers, we do all the lifestyle stuff. So I don't know, I think it's you gotta be careful. There's practitioners out there that really like, I don't know, do all this testing, all this saliva testing, then I'm gonna tweak your dose based on this and come in every 3 months. I feel bad for the patients. Like, I don't think it's always necessary. It's like a money maker for the labs, for clinicians, but I don't really think it's necessary. Is it necessary? I feel bad. Patients need to know there's options, right? You know, if a patient wants it, great. They don't need it.
How about women with hyperlipidemia? Is there any contraindication?
No. No, in fact, it can help, can reduce it.
My lipid numbers went up, and if I tell you, had nothing to do with my food or anything.
Oh, sure,
else.
it's genetics
just-
mostly.
Yeah.
So I do like to have, especially if a woman's like in her 60s and want to start hormone, I'll get a coronary calcium score. Let's get a look and see the artery, any calcification. Make sure that's okay. You know, that's what I would look at as we individualize and discuss risk. And so if someone has really high cholesterol, it's usually genetic, and you know, I like to look at the arteries of the heart to see if there's any plaque deposits.
Is that that's a scanning?
It's a CT scan.
CT scan,
Yep.
right? Yeah.
Yes. So I guess this is going off the same type of question, but let's say someone is over 60, 10 years past menopause coming in, would you personally say the benefits still outweigh the risks, or is it kind of dependent on the person
Yeah,
at that
I think
point?
they usually do. It depends what the patient's experiencing.
Okay.
But yeah, the risks are very still slim.
Okay.
Thanks, guys.
Thank you.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. If you would like to work with me personally to help you improve your health, I do accept a limited number of new patients per month for a functional medicine consultation. Some of the areas I specialize in include helping patients with specific health issues like gut problems, neurodegenerative conditions, autoimmune diseases, cardiometabolic conditions, or for an executive health screen and to help you promote longevity and take a deeper dive into some of those factors that can lead to chronic diseases along the way. Please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we'll set you up for a new consultation for functional medicine. And I look forward to speaking to everybody next week.